let's get into the second part of our central nervous system lectures and start talking about anti-epileptics. And when we talk about anti-epileptics, well, that has to deal with epilepsy. And epilepsy are chronic seizures, and seizures just abnormal electrical activity going on in your brain. So we need to quell that abnormal activity. There'd be a lot of causes for epilepsy, and we typically reserve the term epilepsy for chronic seizures, but seizures can just be caused by a multitude of issues: head trauma, brain tumors, even hypoxia, low oxygen levels, hypoglycemia, alcohol withdrawals, and even fever. So, a lot of things can cause seizures, and we're going to talk about how to medically manage these seizures with medications. And with epilepsy, we have recurrent seizures. And these are just chronic seizures. We just have seizures. There's no other explanation for them. There's no head trauma. There's no hypoxia. We just have chronic seizures with these patients. And when treating these patients, when managing these patients, these epileptic patients, these seizure patients, we want GABA stimulation. We want to inhibit glutamate. Remember, that's one of our amino acid neurotransmitters. Glutamate does. So we want to inhibit glutamate. Inhibit glutamate, stimulate GABA, and we're looking at this inhibition. So we're playing with sodium channels, we're playing with calcium channels. So we're trying to slow everything down, and we're trying to inhibit this excess um, stimulation in the brain. Some popular anti-epileptic drugs that are out there. You see your patients on these. They take them every day. We've got Tegretol, phenobarbital, Dilantin, and Depakote. So these are very commonly prescribed medications for chronic epilepsy. And they all work in kind of different ways. Tegretol blocking sodium channels, phenobarbital as a barbiturate, um, stimulating GABA. Phenytoin or Dilantin is inhibiting both sodium and calcium. And then your Depakote is kind of a combination of all those, playing with sodium, calcium, while also stimulating and enhancing GABA. Couple older drugs for you. For epilepsy, we've got gabapentin. Trade name for that is Neurontin. It's a GABA analog, so it does GABA stuff, slows everything down. And we also have Lamictal. Might see your patients on Lamictal. These inhibit the neurotransmitter glutamate. They also block sodium channels. And one of the big side effects to Lamictal is Stevens-Johnson syndrome. And we've got a patient there, a picture of a patient there for you. And in Stevens-Johnson syndrome, these are essentially burn patients. It's an autoimmune response that kind of eats up, burns up your own membranes, and starts in the mouth and is very painful. If you encounter a patient like this, they should be going directly to a burn center. Now, in the emergency setting, we have our own anti epileptic drugs, and we're going to be encountering patients in status epilepticus, which is just continuous seizing. So they have multiple seizures, they're not regaining consciousness in between, and these seizures are lasting a long time. So, most typically, your patients will have a seizure, they'll seize for 10, 20, 30 seconds, and their body will stop seizing on its own. But these status patients continue seizing over and over and over again, and they don't come out of it. So we have to step in with our own medications, and that's when we go in with our GABA medications. We go in with our benzodiazepines. We go in with our barbiturates. So we've got midazolam, diazepam, lorazepam. We've got phenobarbital, which is our barbiturate, and we can also give phenytoin, or that Dilantin that we just hit just a minute ago. All right, moving on from GABAs, let's talk analgesics. So analgesia, fancy medical term for let's decrease your pain. So how are we going to decrease your pain? Well, we can block um, pain communication from the source, from the site, through your spinal cord to your brain. We can do it that way. We can or we can block pain directly at the site. And that's where we're going to get into our differences between our opioid analgesics and our non-opioid analgesics, like our NSAIDs, or non-steroidal anti-inflammatory drugs. So how do we differentiate between the two? Well, our opioids are acting on our central nervous system and in the spinal cord, and they are blocking the communication. They're blocking that transmission of that pain. Our non-opioids, like our NSAIDs, or non-steroidal anti-inflammatory drugs, we're blocking the actual pain impulse at the source. So your non-opioids acting on your peripheral tissues, say, on your finger, you put down on that sharp tack. Our opioids acting within our spinal cord in our brain to block communication of the pain that has been already felt. And when we talk about pain, there are three kind of broad categories, flavors of pain. We've got somatic pain, which is dermal tissue pain, so you get punched, or you put your hand down on a hot burner, hot stove. That is somatic pain acting upon you. Then we have visceral pain, and the best way to think about visceral pain is kind of this internal pain. So think of abdominal pain. So you've got something inside of you that is suddenly hurting. Nothing's been acted upon you. You haven't been punched. You're not burning. You haven't been stabbed. But we've got this visceral pain. So I've got pain in my abdomen, and that's visceral pain. Then we have neuropathic pain, which has to do with our nerves. So nerve damage causes neuropathic pain. There's no other other explanation for it. I just hurt. Maybe it hurts to touch me. So I have neuropathic pain on my hand. Even you touching my hand causes this sharp pain. So we see this in issues like fibromyalgia. We have this neuropathic pain. Now, if we want to treat pain, we can go for our opioid receptors. We have lots of opioid receptors in our body, in our central nervous system, and these come in three types. We've got mu receptors, kappa receptors, and sigma opioid receptors. Our mu receptors are the ones that our medications that we're giving are going to go after the most. So we get the most pain relief from our mu receptors, but we also get some respiratory depression, acts on the GI system. We get a little bit of euphoria from this. So we're giving morphine, we're giving fentanyl, we're giving codeine, or maybe your patient is on heroin or has taken heroin. So we're getting these side effects and these analgesic effects there. If we go after kappa receptors, less pain relief and more sedation. So we get more sedative effects but less pain relief effects. If we go after sigma receptors, we get some pretty big effects when it comes to hallucinations and dysphorias. If we give morphine, pretty strong opioid medication, well, it's got a very high affinity for those mu receptors and some affinity for kappa receptors and sigma receptors, but primarily those mu receptors. So we get a lot of pain relief, we get some sedation, but we're going to get a little bit of euphoria, a little bit of happiness. We're going to get some nausea, vomiting with morphine because of histamine release, and we really have to pay attention to respiratory depression. So if you're giving any of the opioids, especially morphine, we're paying attention to respiratory effort because we don't want to lose track of that. And with morphine, we get some vasodilation, again, because of that histamine release. And with this, you give morphine, you're going to see a drop in blood pressure. So pay attention to blood pressure. If you have a patient who's already hypotensive, let's hold off on the morphine or go in a different route. We still want to treat their pain, but we're going to go in a different route because morphine will vasodilate, will drop their blood pressure. And you're going to have patients, especially cancer patients, on morphine every day. taking morphine as a prescription at home. And one of the big side effects, longer term side effects of morphine and these opioids is this decreased GI motility, and some fancy word of saying they're going to be constipated. So constipation is a longer term side effect of these opioids, especially morphine. Then there are other opioids that we can give, and you'll see we've got fentanyl. Fentanyl is amazing. Is one of our most potent opioids out there. So small concentrations can go a long way. They are available as transdermal patches. You might have your patient on a transdermal fentanyl patch. So make sure to do a good physical assessment, especially on your unconscious patients. They might have this patch on them. So if it's an opioid issue, you see this patch, we can just take the patch off and clean it off. But we can also give fentanyl. We've got Demerol. Demerol is an older medication. Might not see it given quite as much. Might see it in the hospital. There are some major side effects here with Demerol in larger doses. We can see tremors. We can even see seizures with Demerol. Also have oxycodone, which is commonly used in combination with Tylenol or acetaminophen, and used in combination with aspirin. So oxycodone with acetaminophen is Percocet, which you've probably heard of, and oxycodone plus aspirin is Percodan, which you've also may have come across or heard of. So oxycodone is our opioid, and they can be combined with a non-opioid to provide pain relief in a chronic setting. Then we have methadone. Methadone's also an opioid, commonly used for opioid addiction, to try to take this opioid, let's say this heroin addiction, and kind of progressively take this patient away from that addiction, off that heroin, off that opioid. So methadone provides opioid stimulation, which the patient's body needs, but doesn't produce that euphoria, and so they don't get the the sedative effects, the euphoric effects of the opioid, but they still get opioid receptor stimulation. Those were our strong opioids, so we can move into our kind of moderate opioids. So still stimulating opioid receptors, just not as heavily as those previous medications. So if you've got codeine, can be used in combination or used as an antitussive. So for our patients with a bad cough, we can treat this cough with these moderate opioids. We've got Darvon, which is another synthetic opioid, and again, usually combined with aspirin or Tylenol. And then you're probably definitely going to see your patients on Tramadol. So chronic pain, chronic back pains. A lot of these patients are on Tramadol. Tramadol has a strong affinity for these mu receptors, and it also blocks reuptake of norepinephrine and serotonin. And we're mentioning a lot of these drugs in combination with other medications. Well, there are a lot of them out there. We mentioned Percocet, you see, is oxycodone and Tylenol. We mentioned Percodan, which is oxycodone and aspirin. And there are other ones out there. So we got codeine. Is codeine elixir and Tylenol used as an antitussive. We've got Vicodin, which is this hydrocodone and Tylenol. So you've heard of Vicodin, you've heard of Percodan, you've heard of Percocet, and these are medications which have opiates in them, opioid medications, and these non-opioid medications. Well, oh crap, you've got this opiate overdose patient. What do? Well, we have opioid antagonists. We have naloxone. Trade name for that is Narcan. So Narcan is our opiate antagonist, and it's going to go in and block mu and kappa receptors. It's going to block these opiate receptors so that the opiate medication in the patient's system cannot bind to it and cause that sedation. So we're going to give Narcan when we have severe respiratory depression, and it's going to reverse that respiratory depression. Going to reverse that coma, that sedation. Narcan kicks in pretty quickly, but Narcan also has a short relatively short half-life. Narcan's half-life is less than that of all of the opiate medications. So your patient is overdosed on heroin, we give Narcan, they start breathing again, they might come around a little bit, come out of that sedation, and then the Narcan wears off, but the heroin is still in their patient's system, and they go back into respiratory depression and this quote unquote coma. Well, all we do is give another dose of Narcan. So, depending on the amount of opiate in your patient's system, you might have to give multiple doses of Narcan. And speaking of heroin, let's get into some common drugs of abuse. And when we talk about drugs of abuse, we've got dependence, and dependence comes in a couple different flavors. We've got psychological dependence and physical dependence. Your psychological dependence is there's this positive reinforcement when you use that drug or that substance. So you take it, you have this maybe a dopamine release. You have this reinforcement. It feels good, so you just kind of use it. Maybe use it out of habit. Um, then you have physical dependence. So, with physical dependence, you've taken a medication, taken this drug, taken this substance, and over time, your body adjusts, and you need kind of more, a little bit more, a little bit more, a little bit more to get the same effect. We can have physical dependence without psychologic dependence, and we can have psychologic dependence without physical dependence, or we can have both in combination. And the number one abused drug in the United States is ethanol or drinking alcohol. So, alcohol is the number one abused drug in the U.S. It is a central nervous system depressant, and because it potentiates GABA, it stimulates GABA and slows everything down. With alcohol, we also, or drinking alcohol, I should say, ethanol, we also get vasodilation. So it actually decreases body heat. You might feel warm because of that vasodilation and all the blood kind of surging to the surface. But with this, we actually get a lot of heat loss. Some other central nervous system depressants that we've already talked about. We talked about these GABA medications, our barbiturates and our benzodiazepines, and our opioids binding to opioid receptors and causing sedation and central nervous system depression. On the other side of all that, we have central nervous system stimulants like amphetamines, which release huge quantities of norepinephrine and dopamine and get you up and going, but also commonly abused nicotine and even caffeine. Another central nervous system stimulant is cocaine, and cocaine is blocking the reuptake of norepinephrine and dopamine. Used to be commonly available, no longer. It is now a Schedule One drug, but this is another commonly abused stimulant. Other commonly abused medications or drugs are hallucinogens. So we've got a couple here for you. One is marijuana, pretty common, and the active ingredient in marijuana is this THC, which is inhibiting calcium channels and playing around with acetylcholine, dopamine, and serotonin in your body to produce its effects. Then we also have LSD, common hallucinogen, and this is just overactivation of serotonin receptors. And our LSD, depending on the dose, depending on the person, depending on the reaction, can last a long time, up to 12 hours, maybe a little bit longer. So there's a lot of serotonin stimulation, there's a lot of sympathetic system stimulation with LSD. Then we also have PCP, which is inhibiting reuptakes of not only serotonin, but dopamine and norepinephrine. Your patients on PCP, a lot of hallucinations, a lot of euphoria, and just watch out with these patients because they might become hostile. They become really like super strong, and so these are patients that will fight. So just be aware of your surroundings, aware of your patient if they are on PCP. So what are we gonna do? when we encounter these patients who may have abused a medication or overdose on a medication? Well, we've got Narcan, we've got naloxone for our opiates, we've got flumazenil for our benzodiazepines. So flumazenil is a GABA receptor antagonist, so our benzos are binding with GABA, and flumazenil blocks GABA, so the benzos can't do their thing, just like Narcan and the opiates. For our alcohol withdrawal patients, Ativan, lorazepam is a great first line drug for these patients. And then our patients with drug induced psychoses, we have this tranquilizing medication, this dopamine receptor antagonist in haloperidol. Trade name there is Haldol. So these are some drugs we can reach for when managing our drug abuse patients. On the more chronic end of things, your patient might be on methadone for opioid addiction. That might be on nicotine, so nicotine patches, nicotine gums, if they're trying to quit smoking. All right, so to close out our central nervous system topic, kind of that broad topic, let's talk about some neurodegenerative diseases, some CNS degenerative diseases. And here we'll point out a few: Parkinson's disease, Huntington's disease, Alzheimer's disease, multiple sclerosis, and amyotrophic lateral sclerosis, or ALS, more commonly known as Lou Gehrig's disease. First, let's talk about Parkinson's. So, your Parkinson's patients, lots of tremors. Right? So, lots of tremors in the head, in the extremities, even at rest. Just resting tremors and then as the disease progresses, you'll see issues with facial expression, in posture. You might have some drooling, and then we're going to have internal issues as well. And with Parkinson's, it's an issue with dopamine. So our dopaminergic neurons, those nerves, are degenerating. So we have a decreased level of dopamine. We don't have release of dopamine. And then on the other side of things, our cholinergic neurons are being excessively stimulated. So for Parkinson's, what are we going to do? Well, it's an issue of dopamine, so we want to increase dopamine levels. Couple medications here that your Parkinson's patient might be on. One is levodopa, the other is carbidopa. So if you see those dopa medications, those are medications that increase endogenous dopamine levels. Next is Huntington's disease, and this is a hereditary disorder, so something that runs in your family. So if you're at risk for it, hopefully you know about it. You have family members who have dealt with it and have had it. It has a lot to do with involuntary movement and tremors in the limbs, your tongue, your face. It also affects personality. And as the disease progresses, you progress into dementia. This is a medication that kind of shows its face in your 30s. So it's not something that kind of pops up when you're 5 years old or 12 years old or 20. It kind of begins in your 30s and then progresses for another 10, 15, 20 years until the point where your diaphragm and your respiratory, those the chest wall muscles, your respiratory muscles, can't work properly. And patients who die of Huntington's disease typically die of respiratory issues, respiratory depression. So what do we have going on here in Huntington's disease? Well, we have degeneration of our GABA neurons. So your GABAs aren't working as well as they should be, and we have excessive dopaminergic activity. So we need to do a couple things when treating this medically. We need to block dopamine receptors, and the go-to drug there is your Haldol. And then because our GABAs aren't working quite as well as they should be, we need drugs that tickle and stimulate GABA receptors and these GABA neurons. So we can give benzodiazepines. So it's kind of a two-pronged approach for Huntington's disease. Again, there are no cures for these. This is just symptom management. Then lastly, let's talk about Alzheimer's. Pretty common. The Alzheimer's disease is a type of dementia. It is a progressive dementia. And in Alzheimer's, we've got this destruction of our cholinergic neurons. And our cholinergic neurons play a big role in memory. So we think Alzheimer's, classic description of Alzheimer's is you don't know what's going on around you. You don't remember things. So because of the destruction of these cholinergic neurons and this cortical breakdown. So big changes in the brain come with Alzheimer's disease. To treat this long term, to manage the symptoms, we should say, we're going to be giving these cholinesterase inhibitors. So remember, we have destruction of these cholinergic neurons. So we want to inhibit cholinesterase, the thing that destroys these neurons and eats up things on your cholinergic side. So the most common medication for treating Alzheimer's and symptom management is Aricept. And Aricept is one of these cholinesterase inhibitors. As always, if you have any questions, comments, concerns, or cuss words, please let us know.